Hi, it's State Representative Todd Stephens. I am here with Dr. Larry Spector, who is a physician for one of our nursing homes in Philadelphia. And Larry, thank you so much for being with us, a Horsham resident. And I know you're really busy at work, but I appreciate you taking the time to join me today to help illuminate some of the issues you're dealing with, in your professional life down at the nursing home.
Yeah, sure, Todd. Thanks for having me.
Oh, yeah, no problem. So, obviously our nursing homes have been so severely impacted by COVID-19, and I just was hoping you might be able to share some of your experiences. What can you tell us, about what's going on at your facility over the last, month or two dealing with this crisis?
Yeah, sure. So I'm actually the medical director at 2 facilities, and I do round it at 3 total. And it's been very difficult to say the least. I also teach at my medical school, and I tell the medical students that this virus did not read the textbook. In fact, it made the textbook. And in the nursing home population, as we're seeing the numbers that we are with the deaths leading the news every day, it's very unfortunate and almost unfair to lead the news with those kind of numbers, because these patients do not show the classic symptoms that you're seeing with everybody else that's going to the hospital or not even going to the hospital. So it's a very difficult time, regardless of COVID, but now with COVID, it's even harder.
So what did you mean by that, by these patients aren't showing the same symptoms?
So the COVID-19 virus is a very different virus than we're used to. And the way it enters the body through this specific ACE2 receptor, and I'm not going to bog us down on biochem and physiology here, but those receptors are everywhere. And in the elderly patients who can't really, number one, comprehend that they have a fever or check their temperatures or tell you they have a sore throat or a runny nose, they're actually presenting with other symptoms like diarrhea. Sometimes if they have some underlying dementia or cognition issues, they're acting way different than they've acted before. And specifically in the nursing homes that I work, where we have locked units to protect those patients and staff, they act totally different with their behaviors, and you just have no idea until sometimes it's too late to figure out that this was the virus.
Wow, it's got to be challenging. Got to be challenging.
Very.
So what changes have been implemented at the facilities where you're working to try to deal with these issues?
Yeah, sure. So again, this is where I say sometimes the news follows the best story. Once we saw the first COVID patients in Kirkland, Washington, we started immediately planning every day for this virus. We planned, we met, we talked about cohorting, we talked about testing, we talked about temperatures every day in our facility. We made the decisions, which were unpopular at the time, that family members were not able to come in. We had to cut down physical therapy. We then had to ask agency nursing to probably not come if they were at another facility, which would then hinder the ability for our patients to be cared for, because our staff would then have to work harder and longer. And we even discussed how we're going to take patients down the line from hospitals to help the hospitals send patients to us with COVID positive patients. So we had the best laid plans. Unfortunately, the virus and the ability of the staff to manage these patients was not able for us to keep up with the plans that we had.
Right. So in terms of your staff, what are some of the challenges that you've had there, and how are you dealing with them?
So from the beginning, I tried to do sit downs with our staff to educate them on the virus and how it is very scary for all of us and going home to your family, but we have to take care of the patients to the best of our ability, and this is what we all signed up for. And everybody did believe in that until, of course, you get your first or second patient, and then that's when it goes awry. A lot of staff members, unfortunately, decided to either go to their family doctors and get notes that said that they had to be out 14 days, because originally the CDC said you would be out 14 days. Very few staff members were able to be tested or got tested, and then some staff members just decided to resign. The rest of them that definitely wanted to work are still working, and the ones that did test positive are coming back, but it has been a very difficult month of April.
Yeah, I can imagine. So you've got less staff trying to take care of more patients, and patients with great needs.
Correct.
Doesn't sound like a great situation for sure. So how about your residents? I mean, what changes have they experienced? How are they coping with all this?
So a lot of the nursing homes that I deal with, they have a short-term unit where patients come in, say, with a hip fracture or a stroke, and then they have the long-term unit. And each unit has its own problems. So for the short-termers, they came in to get better to go home. So now I had to cut their therapy. I've had to cut staff, so they're not getting attentive of what they wanted, and then they're going home to either their families that can't care for them, or they're staying longer, and then they're putting themselves in jeopardy of possibly getting the virus. Long-term patients are used to having staff members help feed them, help change them, help get them up to the bathroom. They're also expecting their family members to come in and talk to them. Some are actually lucky enough that their family members can see them through the windows. But a lot of them originally, like our plans that I stated, we wanted FaceTime at least twice a week. But when you're down to the bare minimum of staff to take care of patients, that unfortunately had to go away as well.
Yeah, I've actually had constituents call me because they were trying to reach out to their loved ones in a nursing home, not any of the ones that you're involved with, and they couldn't get help just to get their loved one on the phone, and they couldn't understand why there wasn't somebody who could help go and put a phone up or help with an iPad for a loved one. And when I reached out to the facility, the answer was, look, we just don't have enough people to help. There aren't enough hands. We're trying to help people who are sick and get medication and all the other stuff. And unfortunately, in terms of priorities, FaceTime is lower on the list. So everyone was frustrated all the way around. The staff was frustrated because they wanted to connect loved ones with their family members, but a tough situation. How about PPE, personal protective equipment? How have you guys been doing with that?
So that was a problem in the beginning, specifically with the masks. As you know, with the virus, we mask, we gown, we put gloves on, and we use shields or goggles just because of the way that the virus is. The problem is that number one, the testing has a 30% false negative. So if you don't have enough PPE, how do you know which patients you can go into with which gown? So we've all gotten one mask per week, one shield, goggles for the whole time. And then in terms of the gowns, we've decided to get hospital gowns or patient gowns to put on top of us, and every time we go in a room, we then take that off and put it in our linens. But as you know, the turnaround time for our laundry has been decreased as well because they're frontline workers and they're getting sick as well. So my question always is, how safe is it to wear a mask for 1 week? How safe is it to wear the same gown going in and out of patients that you're not sure if they're positive? And then gloves are a major issue. I have, medium-sized hounds. I'm wearing small gloves, and we don't have disposable stethoscopes. So now I'm using my regular stethoscope, and now I don't have Lysol wipes to wipe it down. So how do I listen to a patient's lungs? So even though we're doing well with maybe the masks, but now the gowns and the gloves and then the disposable stethoscopes, and it's just continuing to go on and on because now we've got COVID positive patients coming into the facility from the hospitals along with our patients that are positive and negative.
Wow. It's a trying situation. My gosh, I mean, it seems like it doesn't end. On the testing front, what are you seeing there?
So the testing front, as I said, first off, it's the 30% false negative. So what happens with that, just so you understand, is that we'll do a test and it'll come back negative. The patient 3 days later will become short of breath. We'll get them to the hospital and we'll find out that they're test positive. And at that point, you assumed probably that they were positive when we saw them, but the test came back negative. So that's a problem, number one. Our PCR tests are not great. Second of all, the testing, it's very deliberate getting into the nasal the nasal area and getting up there, and especially with certain patients, they don't give you the best opportunity to do that test. And then you're putting yourself at risk. One of my nurses who did get sick, one of the patients sneezed right at her into her shield. She then was out for 14 days. The third part of testing is how long it takes to come back. Every lab is different. We're using the city a lot of the times, and that can take 5 to 7 days because they're running a lot of tests. And then we're running out of swabs, so we can't even test those patients. The last thing now is that the city has changed their mind, and to get a patient out of isolation, you now have to get a negative test. Well, number one, that test could be falsely negative 30% of the time, and now I've got to wait another 5 to 7 days to get the test back.
Wow. And that's for testing your residents. How about your staff? I mean, have you had do you have enough testing for what you'd like to see for your staff?
No, and there's no guidelines to test staff, Todd, because here's the issue. If I test my staff who's asymptomatic and they come back positive, now, unfortunately, for the protection of them and my patients, they're out for at least 7 days based on the latest guidelines. So it's a real difficult situation because I want to test my staff. I don't have the ability to. Number one, I don't have the swabs or the tests. But then also the test is going to come back 5 days later, and they've already been seeing the patients anyway with possible asymptomatic spread. So it really, at this point, we're not doing any PCR testing on our staff unless they actually have symptoms.
Wow. All right. I mean, these are obviously tough times for you and your staff. Are there any suggestions, recommendations, aside from trying to make sure we get you more PPE, trying to get you the testing that you need? What else can we be doing in Harrisburg to try to help with some of this stuff? Any other thoughts beyond those?
I mean, the first thing that we talk about as medical directors and physicians is, number one, hopefully this antibody testing that we're talking about and seeing is really going to help. The problem that I need help with is once it's able to be done, who's going to pay for that test? I've had antibody testing and I was negative for both IgM and IgG, which means that I didn't have the virus, which is good, but now I still have to protect myself seeing my patient. That test costs $53. If I'm going to test 350 patients in my facility, along with 150 staff members at $53, I don't know where that money's coming from to protect my staff.
Right.
So that's number one in my question to the state legislature.
Yep.
Number two is that if I don't have enough staff, how can I help the hospitals that I reach out to and send my patients that are sick to bring patients back in if I don't have staff and I have limited staff equipment? So that really is another, help that really the state can help. And then just allowing the families out there to know that we're doing the best for their family members. We're really trying to do the best, but in this patient population where we don't have negative pressure rooms, we don't have one nurse per 5 patients, we don't have PPE, and we don't have a lab and a chest X-ray and X-rays on site. Todd, I can't get stat labs anymore because all our outsourcing labs say we can't do them anymore. So you get a time and that's it. And if somebody goes south after that, you're in trouble. And then you have to send it to the hospital, and then they tell you their surge capacity is too large, so why are you sending the patient to the hospital? So we're really caught in the middle here of a crossfire.
Yeah, I can imagine. Well, we're certainly, I'm going to take this information back to my colleagues, and, obviously we're going to work to prioritize you guys in terms of PPE and testing. And, we've got to make sure that we're doing more to support, your efforts. I know there's a lot of talk and a lot of issues trying to provide support for staff. We don't want staff who's sick coming into work. Obviously that's a problem. And we don't want staff walking out because they don't feel like they have the support they need in the event they get sick. So we're looking at some measures there to try to, ease some of those burdens for your staff, and hopefully that can help as well. But as always, if you have any other ideas, please give me a call and let me know, because I certainly want to help. Is there anything else that you think that people in our district need to know about, what's going on in our nursing homes here in PA through the COVID-19 crisis?
Yeah, so I think the biggest thing, and it's been discussed in the news as well, is advanced directives for any patient, no matter what age you are, can really help a situation like this. So as hard as it is as families to come and try and get on the phone with us, it's as hard for us to try and get families on the phone to make decisions at the time of crisis. Some of these patients, as you know, have had major strokes. Sometimes they've had cancers, and they're in our facilities because the families can't care for them. But unfortunately, time or money was never able to have advanced directives. If we have guidance of what we can do for our patients in the facility before they get sick, we can really help the patient. We can communicate with the family what they want, and then we can help our hospital so we don't send a patient that the family or the patient does not want to go to the hospital. As you know, when patients have to make a decision on their own, it's very difficult, and most of the time they're going to err on the side of going to the hospital.
Right. So living wills, powers of attorney, things like that, really important for folks to think about before they're sick.
Correct.
It's one of those things that you hear about all the time, and so many people say, geez, I wish I would have, and now's the time. So, well, Larry, look, I appreciate you taking the time with me. I know your days are trying and stressful, and we appreciate everything you're doing. Thanks so much for sharing what's going on with us so that we can better understand the trials and tribulations of what you and
Yeah.
your staff and residents are dealing with.